The Shift is brought to you by SE Healthcare. Welcome to The Shift. I'm Dr. Andrea Coyle. Hello, everyone. Dr. Andrea Coyle here. So thrilled to have my friend and colleague, Dr. Jamie, with me. We're excited that each and every one of you are joining us. If you could do a quick introduction, Jamie, and then share with everyone what intrigued you and inspired you to come on to the webinar today.
Yeah, so my background is psychiatric mental health nursing. I have been a psychiatric mental health nurse for nearly 40 years. Most of my experience is with children and adolescents, and probably since 1997, I've been primarily more focused on suicide prevention research. So that's kind of like, this is an area that I'm very passionate about. I have lost a student to suicide. I've been around patients who've been lost to suicide, not anyone that was directly under my care, but I've witnessed, providers experiencing that, and it's very, very difficult to manage. And so I was just really interested in coming here to talk about this because, again, this is an area that's near and dear to my heart. I volunteer a lot with the American Foundation for Suicide Prevention and their prevention education to try to get out into communities and educate people on suicide prevention and warning signs and ways that people can reach out for help.
Jamie, thank you so much. And I'm just going to shout out a little fun fact. I'm from Southwestern Pennsylvania, Pittsburgh. So is Jamie. And Jamie didn't mention this, but she's at the University of Pittsburgh. And I have to do a shout out to the University of Pittsburgh. For those of you who don't know, University of Pittsburgh ranks number 4 in their nursing BSN program by U.S. News World Report. They are ranked number 2 for their CRNA and DNP program. And for their psychiatric mental health NP, they're ranked number 5 in the nation. So we are joined today by a rock star. So thank you, Jamie. I'm going to jump right in. I'm going to ask some questions, and we're just going to get started.
All right, sounds good.
You bet. Jamie, the first question. Can you help everyone, all of our listeners, understand the risk landscape for nurses' higher vulnerability for suicide?
Yeah, so, we know that nurses have above average suicide rates compared to the general population, and that's partly due to chronic stress, working shifts, moral distress. We are exposed to trauma nearly every day, and there's a lot of things that play into that. Burnout is another really important piece, and I will thank Michaela because she did send me some of her notes, because this is Michaela's area. One of her areas of expertise is looking at burnout and risk in healthcare providers. So basically, when we think about burnout, it's not a medical condition, rather it's an occupational phenomenon. And so there are a few different definitions related to burnout. One is that from Maslow is that it's a combination of symptoms across 3 main domains, including emotional exhaustion, depersonalization, and a reduced sense of accomplishment or personal efficacy. So, as nurses, I know I can relate to some of those feelings that I felt in the past. And I think it's important that we think about the things that we face every day. The World Health Organization calls burnout a syndrome that's conceptualized as resulting from chronic workplace stress that's not been successfully managed. And they look at 3 different dimensions of burnout, including like energy depletion, so just feeling sort of exhausted and worn out, increased mental distance from one's job, or sort of feeling really negative or cynical about one's job. I mean, we know how staffing can sort of affect how we feel about going to work every day, and especially with acute patients, that can be really difficult. And along those same lines, reduced personal efficacy as well. We do know that there's a relationship between burnout and suicidal ideation, and that has been found in a meta-analysis in 2024, and another meta-analysis in 2025. And so it's just something that we really need to look at. And then the other thing, and I mentioned this earlier, is looking at secondary trauma and burnout. So, things that we're exposed to on a daily basis that, are typically traumatic for people to manage and to deal with on a, just in general. Also, like, losing patients, no matter which area of nursing you're working in. As nurses, we might have a relationship with a patient that we work with for months, and then we lose them, and we're not really always given permission to grieve those losses. So there's a lot of secondary traumas that nurses can experience as well. So, and compassion fatigue. I mean, we all became nurses because we want to help people, right? Like, it's like the reason that we're nurses. But at the same time, we can really start to feel helpless because people are suffering, and that's difficult. All of these things are correlated with, in nurses, and might be related to suicidal ideation.
Jamie, I just want to piggyback on something as you talk about burnout, and that kind of also contributes to the landscape of suicidal ideation and mental health and anxiety and depression in nursing. And I always say this to any presentation that I do across the country about burnout. And I've actually taught a good friend of mine, Tyler Miller. He would say he's a burnout victim. And I said, no, we are burnout survivors. But what I mean by that is, in my career, I have 100% felt the three cardinal symptoms of burnout: the exhaustion, the cynicism, and the lack of self-efficacy. And to your point, we got into healthcare to help people. And when we go home at the end of the day, and because the workload's heavy, because maybe didn't have enough staff, because maybe our leadership didn't make us feel valued or appreciated, and there's a whole long laundry list of things I can go over, but you leave the hospital, you feel like, I've worked really hard. What's the use? Mm-hmm. And that what's the use becomes so heavy that something you can't even weigh on a scale. And then you take that little portable burnout home, and then you might have things going on at home, and you bring that burnout back into the workplace. And it's truly the perfect storm. And so I say, burnout presents different in every individual. It presents differently. So for me, I became critical and cynical. And I would say, what's the use? And then when I would get home, I would reflect on maybe how I behaved, and I wasn't behaving at my best. And then I'd feel guilty. So you get stuck in this hamster wheel, for lack of a better word.
Yeah.
And it can put you in a place of, or a space of, depression, anxiety, or what's the use? And so I just wanted to really expand on that. And hopefully the listeners will take heed and recognize that. And I say this out of true vulnerability. I leveraged my EAP because I recognized that I was not okay. And it's okay to get rid of the stigma that we all have, to admit that sometimes we're not okay.
Yeah, it's difficult. I mean, especially for healthcare providers, I think, because, we're supposed to be the ones caring for everyone else. It's really hard to reach out when we're struggling. And it's so important that we do use our resources like our EAP.
So I'm going to dive in and ask you another question. I think this is why some of the listeners joined us. What are some warning signs that someone may be thinking about suicide?
Okay, so many times we see warning signs sort of lumped into three different categories. And this is kind of like my AFSP hat coming through, because I give a lot of these presentations, through them. But we look at warning signs through talk, mood, and behavior. And so people might indicate that they're struggling by things they say. They might say that they're feeling hopeless. They might say that they have no reason to live. Maybe they feel trapped in whatever situation it is, whether it's work related or whether it's something at home or a combination. If someone sort of mentions being in unbearable pain, and just sort of like there's no other way out. And sometimes they might even talk about ending their lives. And anytime someone mentions suicide, we want to make sure that we take that seriously. They also might display risk factors in terms of their behaviors. Some of the things that we might see are changes in sleep, which can be difficult to judge with nurses because of the shift work. And that can be difficult in general. But I mean, I know that a lot of the psychological autopsy studies have found that sleep is often disturbed in the proximal time prior to a suicide death. And so paying attention to sleep is really important. You might see people using more drugs and alcohol than usual, or turning to drugs and alcohol as a means of coping. Maybe they might be acting more recklessly than usual, taking risks, driving under the influence, speeding, things that they normally wouldn't do. And we often see that. On the other hand, we sometimes see people withdrawing from their usual activities, maybe not participating in social activities, isolating from their families and friends, missing work. So all of a sudden, your coworker is starting to not show up at work, or their work performance is declining. They might be having trouble focusing. And then the last behavior that we always talk about is giving away possessions. Now, these are just some of the warning signs. Obviously, there are more. And then the last category that we think about is mood. And when we think about mood, depression is most commonly associated when we think about suicide. And we know that depression is actually that suicidal ideation or behavior is actually a symptom of depression if you're looking at the DSM-5. But there are some psychiatric disorders that also might play a role, including anxiety, PTSD, substance use disorders. So there's a lot of different things like that. Also in terms of mood, if you're starting to notice more apathy, rage, a lot of impulsivity, or the last one is the sudden unexplained happiness. And sometimes we see that in a couple of ways. One is, sometimes people have been thinking about suicide for a long time. They've been really depressed. They finally decide on a plan, and so they feel relieved that they're going to be out of their pain. So they might seem unexplained happiness, you might see. Or sometimes if someone's just starting on antidepressant treatment, maybe they didn't have the energy to act on suicidal thoughts. So, especially SSRIs can be a little bit activating. And so people may suddenly have that amount of energy that they might be able to act on those thoughts. So these are all some warning signs that you might see.
That's very helpful, Jamie. And, as a peer, this is where it gets a little difficult. As a peer, how do you intervene in a way that is not intrusive? I think that would be difficult.
Yeah, so the best thing is to have an honest conversation with people. You want to trust your instincts. You will also want to assume that you're the only one who's going to reach out. So many times, like, people will say, "Oh, so-and-so's struggling. It looks like so-and-so's struggling. I'm kind of worried about her." And they'll talk about it amongst themselves, but no one ever really reaches out to that person. So you want to assume that you're the only person who's going to reach out. And sometimes it can be awkward, so you want to be okay with the awkwardness. And so when we're reaching out to a colleague, there's a few things. Like, we want to make sure that we just give them an observation. Like, I've noticed that you're not yourself lately. I care about you, and that makes me worried. Just sort of like those are some ways to start the conversation. It's okay to just come straight out and ask someone if they're having thoughts of suicide. I know that many people still worry that will put the idea into someone's head. And in multiple research studies, that's been shown not to be true, that when people are given the opportunity to talk about how they're feeling, it's actually therapeutic and can help them for sure. Another thing that we kind of might feel like automatically might feel like we want to do is sort of debate with them about why their life is worth living and all the things they have to live for. But honestly, when someone's in that moment of suicidal crisis, having a philosophical debate is not going to be helpful for them. And getting them help is what the most important thing is. So, really just reaching out, starting a conversation, letting them know that you're there for them. If there are concerns about suicide, making sure that, they have options of places to go for treatment or referrals or, those emergency services or things like that.
Very helpful. Share with us, the listeners, I'm sure, want to learn, what are prevention strategies for nurses?
So this is where I wish Michaela were here, because Michaela does a lot of work in mindfulness as well. Self-care is really important. We have to take care of ourselves as nurses, and that means taking care of ourselves, like physically, emotionally, like just overall taking care of ourselves. So getting enough sleep, even when it's difficult because of the way we work and families that we're taking care of and things like that. It's also important to find what makes you feel like less stressed or relaxed and more relaxed. So things like maybe yoga or mindfulness or meditation, like find what works best for you. Sometimes it might be exercise, like someone might feel better when they're other people might hate exercise, but the whole idea of self-care is just finding out what works best for you and paying attention to your own body and the symptoms that you're having. And that's really important. Talking about things like as stress is building, finding someone that you can reach out to and talk to, utilizing your employee assistance programs. If you really don't, you feel like you need to reach out to a professional, they can really help you in the short term or make a referral to someplace that can be a more long-term solution as well.
I just want to add on, as I said, I'm a burnout survivor. And one thing I did is I really had a great friend, Laura Smith, shout out to Laura Smith. She was my positivity squad. And I recommend in the workspace, identify one or two, maybe even three, it depends, people that when you're having a moment, that's your positivity squad. And you can speak to them and it's a judge-free zone. Yeah. And that can be really helpful in many situations.
Yeah, that's great. That's great. I mean, that's kind of what we need. We need to have a safe place to go. And sometimes it helps when it's someone who kind of knows what you're experiencing, like maybe another nurse or some, someone that's sort of been there and kind of and can relate. That can be really helpful.
Yeah. This is a tough question. How can organizations create a supportive culture?
Yeah, that is a tough one. A lot of the things that we mentioned related to burnout are really like organizational level issues that could potentially solve those. But we know that that it's difficult to just have them hire more people or something like that. But I think that one of the things that they can do is like sort of encouraging people or creating an environment where people feel comfortable, like talking about their concerns, being open and honest about what's going on. An organization that is interested in suicide prevention, there are several different suicide prevention programs that that different workforces may implement, and so those kinds of things are really, really important.
One thing we had in an organization I used to work is we had a psych nurse liaison, and I worked in the adult intensive care unit. And shout out to Ramita Bonadonna. She was our psych nurse liaison. And sometimes in a busy ICU, you could have potentially 3 patients. It was a 20-bed ICU. You could have, 3 patients coding at the same time. Mm-hmm. And if we had days like that, or if we had a patient that was there and it was something totally tragic, she would come and debrief with us. And I feel like more and more organizations are adopting these type of mediums to help support people in the moment so that they don't carry all that baggage home with them.
Yeah. Yeah, and Michaela had suggested a few other sort of interventions as well, like in terms of systems change, but really providing resources for physical activity and stress management. Those are most effective as well. Mindfulness, obviously, we talked about, but if you work for an organization that is really promoting self-care and making opportunities available for things like that, that can be really helpful.
And I think the key is also creating an environment where people feel safe, like psychological safety. Mm-hmm. Free to say, I don't feel okay, or free to speak up when safety is being compromised, whether to a teammate or to a patient or family. So just creating those psychologically safe environments are really important as we build cultures where people are going to thrive.
Right. And there needs to be a lot of more organized procedures around debriefing nurses when critical events occur. Having that opportunity to debrief, because those are things that we need.
One thing that sticks out to me in my career, during the thing that happened in 2020 that we don't like to call it that thing anymore, I'm just going to call it the pandemic. I worked in a behavioral health hospital in a New York City suburb, and we had a patient who was becoming very aggressive. And after the event, everything's on camera, everything's filmed for safety reasons. the director of that unit came to me and said, I want you to watch this and I want you to see everything that you did wrong.
Geez.
And I think if we shift the mindset to let's find everything you did right, and
Hmm.
then let's identify your opportunities. Because I went home that night, Jamie, and I could not sleep. First of all, because the patient was coming at me. And second of
Right.
all, I was fearful for my life. And then the next day I go in and told that I didn't do anything right at all. It was not a psychologically safe environment.
Right. Definitely sounds that way for
Yeah.
sure.
So for the listeners, it's really positive. Let's find the right, let's find the opportunities, and let's couch it in a way that's helpful, not hurtful. Um, Another question: how can burnout? And we kind of talked about this, but how can burnout mitigation support suicide awareness and management?
I mean, I think that could play a big role because it would really decrease a lot of the stress that nurses and other healthcare providers are facing. I mean, we're talking specifically about nurses today, but we also know that other healthcare providers are also at risk as well. Um, so I think addressing burnout and really listening to the nurses and trying to, do what can be done to mitigate those risks would be really, really helpful. um, from a systems level, even like normalizing things like mental health checkups, and like, just like they do physicals, like we all get a yearly physical, but we all, you know what I mean? We get sick days, but do we really get mental health days? Not really. I mean, we can take a sick day and not tell anyone, but that stigma is still there, right?
And I always talk about something called name it, claim it, tame it.
Hmm.
And burnout, feeling depressed, feeling like I'm not okay, it's okay to name it so that then you can claim it and then you can put the strategies in place to tame it. And I talk about that a lot. Um, for the listeners, Jamie, can we share some emergency resources that might be helpful for the listeners?
Sure. And so probably the one that most people hopefully are aware of is 988. 988 it's the Suicide and Crisis Lifeline. It's available 24/7, 7 days a week. You can call, you can text, and you'll be connected with a trained counselor, a crisis counselor. One of the ways that 988 works is it recognizes the area that you're calling from. Well, it used to just be by your area code. Now there's some more geolocation involved. But just in case the geolocation feature isn't working, it's always helpful to say where you're calling from. And then they connect you with the closest crisis resource center. So depending on the area that you live in, like in Allegheny County here in Pittsburgh, like we have Resolve Crisis Center, and that's where 988 is connected to. But in many of these crisis centers also have like mobile crisis units as well. So those are important resources. The crisis text line is also a very good resource. And I know that like a lot of the kids that I work with really like that because they like texting rather than talking to people on the phone. And you can reach the crisis text line by texting 741-741. And you can text hello, you can really text any words and you'll get connected to them. There is some nurse specific help out there, like the Frontline Nurse Mental Health, like that nurse.org website has some specific resources for nurses. And then, like I mentioned, the American Foundation for Suicide Prevention. So they don't have specific nurse resources, but they do address through their Talk Saves Lives with risk factors. They do talk about warning signs and risk factors and why healthcare providers are at higher risk than the general population. So they do provide a lot of education as
Um,
well.
the, all really helpful. And I just want to really emphasize in your organization, find out about EAP and ask questions about resources. The other thing I wanted to shout out to is the American Psychiatric Nurses Association. I always thought you had to be a psych nurse to join, Jamie, but Lisa, who's the executive director, shared with me that anyone can join the American Psychiatric Nurses Association. So that might be a good resource. Um,
Yeah, and if you go to apna.org and click resources, there's a resource page about different psychiatric disorders, different mental health conditions that people might have. We do have a resource page on suicide prevention. I'm very active in the American Psychiatric Nurses Association along with Michaela. And basically we're both, I'm the chair of the Child and Adolescent Steering Committee, and Michaela sits on that committee as well. And also I'm on the Research and Scholarship Steering Committee. But Michaela and I worked on the APNA youth suicide prevention position paper together. And that, so that was a really important product as well. So APNA is out there. They just today released a bunch of suicide prevention resources for a new position paper for adults and for all ages. So apna.org is another great resource.
Thank you for that. So I do want to share something. Cheryl Holden said in the chat, I have a hula hoop and a swivel desk located in my office. When I get frustrated or need peace, I use these two exercise equipments for coping. Cheryl, thank you so much for adding that. That's
thanks
amazing.
for sharing. That's great.
And then Donna Mador, you have a question? I'd love for you to ask the group the question.
I'm sorry, I'm driving, so I must have hit a button. I did not have a question. Thank you.
So you don't have a question. Okay, sorry, Donna, to put you on the spot. You were just, your hand was up. Does anyone have any questions they want to ask myself or Jamie, or any thoughts? We are always seeking feedback. This is the first time we've done a webinar. We want to continue to bring helpful information to nurses at large. Thumbs up, put something in the chat. Helpful. What do y'all think?
I see in the Q&A that the chat is disabled. I don't know if that's been corrected. Oh, no, I see it's something in the chat. Okay. There's also a question where someone's asking for the most up-to-date criteria from the DSM-5 on depression, and how can depression be deciphered as something more chronic rather than acute stress? So the major criteria for a major depressive disorder, they really haven't changed. You still need to meet the symptoms, and they include depressed mood or anhedonia. So you have to have one of those two symptoms or both. Sleep disturbances, appetite disturbances, decreased energy, decreased ability to concentrate, could have psychomotor agitation or retardation, suicidal thoughts or behaviors are also a symptom of depression. And I feel like I missed one. I think there were 9. Because I don't have them in front of me. I'm just trying to rattle them off. But those are the main symptoms of depression. And the other part of the question about chronic versus acute stress, we know that our HPA axis gets activated when we're put under stress, right? And so we might have acute stress as we are repeatedly exposed to that acute stress. The HPA axis is trying to reach this homeostasis, and eventually, so it might be in the state of like chronic activation and chronic stress, to the point where actually the HPA axis can eventually become blunted because of that, because it's trying to compensate for that constant stress. And that kind of stress is a risk factor for both depression, PTSD, and also anxiety disorders, and also for suicidal thoughts and behaviors.
Thank you, Jamie, for that information. So I want to ask this question for you, Jamie. What was the text line again, please? Was it 741-741? Those 6 numbers, 741-741, and then you can text the word hello, or just text, any word really. You can text talk, hello. As long as you send some text to that number, you'll get connected to a trained counselor 24/7. And then I just want to share something Eugenia Smither put in the chat. Is she works in end-of-life care, and they have adopted a code lavender. I hear a lot about code lavender. And just quickly, it's when an event occurs, people go up and they provide briefings and tools and resources right after the event, which I've seen that be incredibly successful. It's evidence-based.
Yeah, that's amazing.
And then someone else said that they use Schwartz Grand Rounds as well as a safe place to talk about things like when you make a mistake, which I don't know about y'all, but I've made medication errors in my nursing career, and it is devastating.
It is
devastating. So I forget who said that. I'm going to go back and see if I can see your name real quick. Schwartz Grand Rounds are fabulous. I've participated in them before. Having open forums where it's judge-free is also very cathartic to just talk about things and be validated.
Mm-hmm. Yeah, definitely.
Let's see. I'm going to check in to see if there's anything else. Can you cover confidentiality? Many of us are mandated reporters for patients, but what about colleagues?
Yeah, so the mandated reporting requirements vary by state. Like, for example, in the state of Pennsylvania, we have mandated reporting regulations regarding like child abuse, elder abuse, those kinds of things. When it comes to like suicidal thoughts and behaviors, I'm not sure that it actually falls under those mandated guidelines, but we do like always encourage people to reach out for help. And if there's ever any concern about someone's safety, it's just important that you reach out. I mean, if they're angry, but at least if you let someone know, or you reach out to them and they refuse to do anything, and you really feel like they're going to do something to end their life, it's important to reach out and cover that topic.
Yes. And with that, thank you, Jamie. Thank you, listeners. Anything last you want to say, Jamie?
No, just that, I talked a lot about mindfulness as a self-care tool, and that's the interview that Andrea did with Michaela. So that is recorded if you're interested in looking at that. It's a great one.
Wonderful. And remember, your shift makes a difference. Keep shifting. Enjoying the shift? Help us reach more nurse leaders by rating and reviewing us on your podcast app. It takes just a minute, but makes a big impact. Search for The Shift, tap those stars, and share what you love. Your feedback shapes our future episodes and helps others discover us. Remember, rate, review, and amplify The Shift today.